This is On Target St. John's, a look at politics, crime, education. What's happening here with the people who know. The views and opinions expressed on this program are not necessarily those of this station. Now, your On Target St. John's host, Linda Swain.
Good afternoon. It is Carrie Hodder filling in for Linda Swain on Target St. John's today. And well, you may not realize this, but October is a very busy awareness month. It is ADHD Awareness Month. This week is OCD Awareness Week. It's also Learning Disabilities and Dyslexia Awareness Month. And here to talk to us about some of this awareness going on is Dr. Janine Hubbard. She is the president of the Association of Psychology of Newfoundland and Labrador. Dr. Hubbard, thank you for joining us once again.
Oh, thanks so much. Good afternoon.
So what is it with all of these awareness months? Why is it important, first of all, I guess, to bring awareness to these topics?
Well, I think these are topics that are often misunderstood, often because particularly in terms of things like ADHD and OCD and even learning disabilities, they're often popularized in pop culture, in movies, in TV show plots, but without people really properly understanding them. And the other thing is, particularly for things like ADHD and OCD, we don't necessarily have like a local support group, or we don't necessarily have, kind of a group able to advocate and talk on a regular basis about what this is like. And these are conditions that actually affect quite a substantial percentage of the population.
What's the prevalence of ADHD here in Newfoundland and Labrador?
The estimates are roughly 4 to 5% of the population.
Wow, that's very significant. And it seems like that has grown over the years. I mean, I know when we were growing up back in the 70s and 80s, we didn't really even know that ADHD was a thing. And now it seems, well, you just said it there, 4 to 5% of adults and children worldwide have ADHD. So why is that?
Well, I think you're absolutely right. Growing up, we might have picked up on the most extreme cases of hyperactivity, impulsivity, but we certainly didn't pick up on a lot of the other conditions. Listen, I started my training back in the 90s, and at that point, we still thought that kids outgrew ADHD. So this is an ever-evolving, changing bit of information, and our understanding and our knowledge of all of these conditions continues to grow.
What exactly is ADHD?
Great question. Because here's the thing. If you have met one person with ADHD, you've met one person with ADHD. It has such a variable presentation, and this is also what leads to a lot of the confusion and the dismissal from a lot of people going, oh, they don't have ADHD. That's not a problem. ADHD, in our current conceptualization of it, because like I say, this keeps changing, it comes in 3 different subtypes. We have what people think of historically as the classical presentation of ADHD, which I should actually say as we're rambling these off, attention deficit hyperactivity disorder, ADHD, is the hyperactive impulsive presentation. That's the leaping without looking. That's the blurting things out. That's the person who has trouble taking turns in a conversation and is just so desperate to share their information that they interrupt, they blurt, they have trouble staying in line, taking turns. That's where you often see the motor hyperactivity. So these are the kids, especially in boys, that get picked up first, because they're the little boys who are running around the classroom and having trouble sitting still, having trouble staying on the mat for circle time, climbing on the furniture, falling off the monkey bars in the playground. That's kind of your classical presentation of it. And we can talk in a little bit about how that looks in adulthood. The second type is the predominantly inattentive. These are the daydreamers. These are the individuals who are easily distracted. It could be by something like a truck going by, but it could be they're distracted by the ticking of a clock or the buzz from the overhead fluorescent lights, or the fact that, hey, there's a really cool spider up in the spider web in the corner of the room that no one else has noticed, but they're fascinated by it, and that's where all their attention has gone. These are kids who are often misinterpreted as being oppositional or just not following the rules. You send them upstairs to go and get their sweater, and you come up 20 minutes later and they're playing with their dinkies. Well, it's not that they were defiant. They got up there, forgot what they were supposed to be doing, and got distracted by something that was far more interesting. And then the third presentation is what we refer to as combined type. So it has features of both hyperactivity, impulsivity, and some of the inattention.
Okay, interesting. And is there one that's more prevalent here in Newfoundland and Labrador or worldwide than the other?
No, and again, I think how it looks gets picked up differently. As I sort of said, the predominantly hyperactive impulsive is often picked up earlier because it's very outward. You see it a lot more in terms of physical agitation. Again, you see those verbal outbursts. You see more in terms of actions. Inattention often gets picked up much later, particularly if you're smart, particularly if you're a girl. That's probably, if you are a bright, inattentive female, that may get missed until you are well into your, university years or even into adulthood.
Why is that? Has there been any studies on that?
Absolutely. Well, and again, ADHD presents a little bit differently in girls, and it's often misdiagnosed as either anxiety or depression. Because even things like the motor activity, whereas in a young boy you might see them, kind of poking the kid next to them or getting up and moving around, little girls might sit and twirl their hair. It's that same motor activity. They're still getting that need to fidget, that need to move out, but it's often in a much more socially acceptable way. Again, it sounds awful, but we accept kind of the chatty Cathy. We accept the little girl who's very, very verbally dominant as more kind of culturally or societally accepted, and it's only until much later on that we realize, oh no, actually they've been having a lot of trouble. They're really good at making friends, but they have trouble keeping friends. So we see a very different pattern emerge, and historically we've always thought that the ratio was about 2-to-1 males to females, but what we're now starting to understand is it may actually be a little closer than that. It's just we haven't been picking up on the girls.
Interesting. I do know a few females that have been diagnosed with ADHD in adulthood.
Yep.
They had no idea that they had this going on all throughout their childhood, and they wish that they had now because they realize that, they struggled in school, they struggled with concentration kind of thing, and now they realize why, and it's a big relief to them to be finally diagnosed as an adult. How often do you see that happen?
That is, I'd say, one of the main things we're seeing right now, because we've gotten so much better at identifying it in kids. We see learning patterns, we see behavioral patterns, we see emotional patterns and social patterns that teachers are very good at picking up on. So we understand kind of the red flags. But what we have are several generations of parents, particularly 40s, 50s, 60s, but even people in their 30s. And oftentimes they're getting picked up either through listening to information sessions like we're having here today, or because their children are being diagnosed. And because we know there is a very strong genetic factor in this, that's one of the very first questions I ask when I'm making a diagnosis in a child, is I kind of look at both of the parents and say, does this sound like either of you? And that often begins a process. And adult diagnosis is such a mixed bag. It's a huge relief for a lot of people. It's there's a classic book that was published years ago, You Mean I'm Not Crazy, Lazy, or Stupid? But a lot of traits that people had internalized and blamed themselves for and just thought, why can't I get things done? It's a character fault. It's a flaw in me, as opposed to, and we also know it has a massive effect on things like relationships. So it's often post-divorce that people are getting this diagnosis and realizing what an impact that it perhaps had on past relationships. People look at it and go, there's a lot of if-onlys. So there's a lot of grief and mourning and processing of how different might my life have looked like if I'd had this answer 20 or 30 years ago.
Right.
In addition to I finally get it, that makes so much sense. Now I understand things, and now I can explain it. I can explain it to my boss, why I have so much difficulty on this type of a task, but yet I just rock it if you give me this kind of a task. Or being able to talk to your spouse or your partner or even your kids and say, look, I know it drives you nuts when I am constantly late picking you up from soccer practice. I have this bit of time blindness that comes along as part of my ADHD. Here's what I'm going to try to do to accommodate for it. Here's what I'm going to try to do to make more of an effort. And it's not just that I don't care.
Right. So, it seems like it would be a relief, as you say, for an adult to get diagnosed because they know kind of what's been going on in their brain for all these years. But it seems that some people are reluctant to have their child tested for that. Why would that be?
There is still, unfortunately, a perceived stigma around the label, particularly around ADHD. I think, unfortunately, there's still some belief that, well, it's just caused by bad parenting, or, if the kids just had more structure in their lives, if they had more routine, they'd be fine. You often get that, especially from, say, grandparents. And there is but I'm afraid the school will label him, or I'm afraid that because they have that label, they'll get written off, or they won't be given as many opportunities. And in fact, it's the exact opposite. I cannot stress enough the importance of early diagnosis, early understanding, and early interventions. And we can certainly talk a lot about what happens when you're not diagnosed and you're not treated appropriately, because unfortunately, while this is a condition that can have some amazing strengths that come along with it, if not treated properly, it can unfortunately have some really negative consequences as well.
Okay, when we come back, we're going to take a short break here now. We will talk about some of those treatments and how you can control your ADHD or kind of get a better handle on it, I guess. I'm Carrie Hodder filling in for Linda Swain here on OnTarget St. John, speaking with Dr. Janine Hubbard, the president of the Association of Psychology of Newfoundland and Labrador. We'll be back right after this.
Now back to Linda Swain on Target St. John's on VOCM.
It is Carrie Hodder back with you once again here on Target St. John's, filling in for Linda Swain this week. And my guest today is Dr. Janine Hubbard, the president of the Association of Psychology of Newfoundland and Labrador. We're talking about ADHD right now, as it is ADHD Awareness Month. And Dr. Hubbard, ADHD is a neurodevelopmental disorder. What exactly does that mean?
Well, what that means is it is a condition that we see differences in brain structure and function. So it's not, as we sort of said, just something that's a result of, poor intentions or poor parenting. We know that people with ADHD don't have enough of a couple of neurotransmitters, in particular dopamine and norepinephrine. I can never say it right. There we go. And so we know that their brains just aren't receiving information in quite the same way. In fact, this is probably one of the most fascinating things, or I find fascinating things about ADHD. People think of it as, being hyperactive, having an overactive brain. In fact, what we know is that people with ADHD have an underactive system. And in fact, the reason that they're engaging in all that motor activity is basically to kind of wake up their brain, to get it moving, to get it acting, which seems totally contradictory to what you might think of. And the best analogy I can give is, think about it. If you're having to sit down and work on something that's going to require an awful lot of brain power, what do? First of all, we structure our environment, so we try to take away as many distractions as we can. And most of us go and pour ourselves like a cup of coffee or a cup of tea, or grab a Pepsi or something with a good jolt of caffeine in it, right, to help us focus. That's essentially what the medication is doing to help out somebody who has an ADHD brain.
When I was growing up, anyone that had ADHD would automatically go on Ritalin. It feels like, you knew which kids in school were on Ritalin because they talked about it, and they were often the hyper kids. What is the treatment for it now?
What we do know is, because, like I say, it's involving neurotransmitters, about roughly 70 to 85% of individuals do benefit from a course of medication. Some of them are stimulants, some of them are long-acting stimulants, some of them are different classes of medications, but we do know that that's one part of the treatment. However, the gold standard of treatment is a combination of drug therapy as well as behavioral interventions. And that may involve restructuring something like, I say, your work environment. That may involve accommodations. That may involve things like some behavioral therapy, some family therapy, some marital therapy to help adjust to some of the deficits that are happening.
Okay, one of the myths that is out there about ADHD is that people with ADHD just have to try harder to pay attention to focus. Why is that a myth? That's not true.
That is the equivalent. Again, one of my favorite books around ADHD is called My Brain Needs Glasses, and that's exactly the analogy that I use. That's like asking me to take out my contacts or take off my glasses and just see harder, see better. I can't. That's how my eyes are structured. It's the same thing for somebody with ADHD. The way their brain is working is it's producing these deficits, and it's not a matter of effort. In fact, my goodness, in a lot of cases, you will never find harder working individuals who are really trying to compensate, but really struggling in terms of management of a lot of symptoms. One of the other things that I think is really interesting and is often misunderstood is people think about ADHD as being a lack of attention. It's actually not. It's a difficulty regulating attention. It's a difficulty knowing where to put my attention and how much attention to put on it. So one of the strengths that comes from ADHD is the ability to hyperfocus, to really get into something. And we hear this complaint about kids in video games, but they really get into something and they have difficulty leaving it and moving on to something else. So shifting that attention. In the same way, the example I gave earlier, you're sitting in class, you're supposed to be listening to what the teacher's saying, but your attention is entirely focused on that spider in the spider web up in the corner. It's not that you're not paying attention, it's just you're having difficulty regulating where your attention is supposed to go.
This is also Learning Disabilities and Dyslexia Awareness Month as well, but ADHD does not fall under the umbrella of a learning disability, does it? A lot of people might think that it does.
No, although the two of them do co-occur with a high rate of frequency, somewhere between about 25 to 50%. So we know that individuals with ADHD, it can have an impact on their learning and their productivity. But that isn't necessarily a learning disability, but it is also something that can co-occur. So that's also one of the reasons why, especially in kids, it's so important if you suspect ADHD to also be making sure that you're assessing and looking for information regarding learning disabilities.
Okay, interesting. Do people ever outgrow their ADHD? I mean, I know that you said, back when you were learning all about it, they thought that everybody outgrew ADHD, but can you outgrow it? Can you be cured?
No, it is a lifelong condition, but it's going to look different at different times in your life. So, for example, that little kid who had the very outward physical hyperactivity when they were running around, as an adult might be someone who sits in meetings and needs to fidget and click their pen, or have a foot that fidgets, or need to doodle. So they've found ways to make some of that hyperactivity more socially acceptable, but it's still happening. So again, it can look really, really different. The other thing is, like all of us, we go into careers and educational paths that maximize our strengths and minimize our weaknesses. So if you're somebody with ADHD, you do very well when you're being asked to be creative, when you're asked to do novel problem solving, when you're asked to think outside the box. You don't do so well if you're being asked to do really tedious, repetitive, mind-numbing tasks. So you're ideally going to find yourself in a job that you can pull to your strengths. So when people ask about medication as well, I have lots of people who perhaps use it to get through school, and then once they're in a job where they're thriving, they may say, no, I'm okay, I don't need that anymore. In contrast, I've had other people where, maybe they got through school okay, but suddenly now they're at something more unstructured like university, and that lack of those really regular accountabilities and deadlines is making life more challenging for them. So it's one of those things that people use throughout life, depending on what's going on, depending on what's happening in their life circumstances, their employment circumstances.
It's interesting, you talk about the lack of ability to focus for a long period of time. I think that I chose radio because my deadlines are always kind of minute to minute, and everything's happening now so fast. If someone's
should I tell you that journalists have a high rate of ADHD?
I'm not surprised, honestly, because if someone asks me right now what's happening 2 weeks out on VOCM, I'm going to say, I have no idea.
But there's some people who can thrive on those kind of the adrenaline. And again, we talk about that, what gets your system revved up. It's that adrenaline. That's why people wind up doing assignments last minute, because if you try to do it 2 weeks ahead of time, there isn't enough adrenaline. There isn't enough of that oomph to kick you into gear. So it's but it's due at 8 o'clock tomorrow morning. Now I've got the adrenaline going. Now I've got that internal kick to make it happen. We see the same thing, people who work in emergency medicine or EMTs. That's another group that tends to have very high levels of ADHD. Really creative people who perhaps don't work under such a structured environment, actors, comedians, performers. We know that there are high levels of ADHD in that group of individuals. But yes, I have teased and worked with a number of your colleagues, and we've talked about the level of ADHD in journalists for sure.
Yeah, I'm really not surprised actually, because like you say, we are, minute to minute deadlines all the time here, especially in radio where everything is immediate at any time during our conversation right now. Some news might break and I might have to pivot and do something else, but it makes it exciting and every day is different. So,
and that's the sign of having found something that fits your personality, that fits your strengths. And again, that ability to hyperfocus, that ability to suddenly go, okay, I got to hunker down now for the next 10 minutes and get this ready, is a real strength. There are other people for whom that kind of rapid fire lack of predictability would just be a nightmare for them.
Huh. Does ADHD often go hand in hand with some other behavioral disorders?
We do know that there's a number of other things that can occur. In kids, we always have to be careful. There are some things around oppositional behaviors and some conduct issues that can co-occur. Really, if untreated, we've got a lot of stuff that can co-occur. In particular, addictions, because we know that oftentimes people self-medicate. Whether they know they have ADHD or not, they know that there's something that doesn't feel quite right, so they look to see what they can do to make themselves feel better. So unfortunately, we do see a lot of self-medication through drugs and alcohol for sure, as well as cannabis.
So are people with ADHD, are they less inhibited then, and that kind of, leads them down the path of self-medicating?
That can be. Unfortunately, again, untreated, undiagnosed, we know that there can also be really high levels of depression and anxiety, which, of course, are also things that can lead to self-medicating.
Okay, great. Dr. Hubbard, we're going to take a quick break here on Target St. John's. It is Carrie Hodder filling in for Linda Swain, and I've got Dr. Janine Hubbard on the line. We're speaking with the president of the Association of Psychology in Newfoundland and Labrador. Stay tuned.
Now back to Linda Swain on Target St. John's on VOCM.
Good afternoon once again. It is Carrie Hodder filling in on Target St. John's. Linda Swain's on vacation this week, and my guest is no stranger to the airwaves here on VOCM. It's Dr. Janine Hubbard, the president of the Association of Psychology Newfoundland and Labrador. We're talking about ADHD right now. We're going to get into some learning disabilities and dyslexia as well, because it is Awareness Month for that, and it's also OCD week, which is obsessive compulsive disorder. So we'll get into that in just a little bit. But for right now, we're still talking about ADHD. And Dr. Hubbard, I was wondering, what is the process for someone to go through to get diagnosed with ADHD, whether they be an adult and they want to go get themselves checked out, or for their children?
Oh, this is such a great question, and I wish that this was more straightforward and readily available. This is one of the huge gaps that we have in our system, particularly here in this province. So bear with me. There are a couple of professions that are able to make the diagnosis of ADHD. It could be a physician, it could be a psychiatrist, could be a pediatrician, or could be a psychologist. And so there's a couple of ways to access each of those venues. So if you are concerned about your child, the very first thing you should be doing is speaking with your child's teacher and or a guidance counselor and expressing some of your concerns. There are, both for adults and kids, some very easy first steps that we can do, which are looking at some behavior symptom checklists. So, for example, for kids, we might get them to fill in one if they're over the age of 8. We'll get parents and we'll get teachers to fill them in, and we'll look and see, is this child having more of these particular symptoms than other kids their age? And if they are, that's kind of a red flag that says, well, maybe we should move forward with that. Maybe we should look in terms of a bit more of an assessment. And again, then that might be looking at a referral to a psychiatrist or a pediatrician, or it might be looking at a referral to a psychologist. For adults, I highly recommend checking out the website. There's a group called CADDAC, C-A-D-D-A-C. Their website is just caddac.ca. And they have some checklists that are there that are available both for children but particularly for adults. And if you are an adult who is wondering about this, go take a look at those forms. Have a significant other fill them in for you as well to give some input. And then first step is go have a chat with your family physician. Some of them are quite comfortable making the diagnosis themselves. Some of them are then going to look at making a referral either to a psychiatrist or to a psychologist. Unfortunately, we don't have a lot of services within the public system at the moment in terms of ADHD diagnosis, particularly within the adult system. So I always do encourage people, if you have EFAP coverage or basically insurance coverage through your workplace, either with an employee family program or with private insurance, it's really worth checking out. The other thing that I would encourage lots of people to do is check out both the CADDAC, C-A-D-D-A-C, as well as CADRA, C-A-D-D-R-A. Both are national Canadian organizations. Both of them are having conferences. One is this weekend and the other is the following weekend, with an amazing array of information that's available. And because they're doing them virtually this year, I'm excited. I'm spending 2 weekends listening and learning about ADHD. Probably not everybody's idea of a fun time, but I can't wait. But really interesting, useful resources and information. And CADDAC in particular has lots of either free or very low-cost webinars from their past presentations that you might find helpful.
When it comes to children being diagnosed, is it often teachers that first see these red flags before parents do?
It is indeed. Well, it depends. Again, it depends on how it's coming out. If you're just really inattentive, that might get chalked up to a whole lot of other things, including poor effort and poor motivation. If it's a really active child, it may get picked up. Something that is important to know is we don't make the official diagnosis until kids are 6. Now, doesn't mean we don't see symptoms. In fact, we usually see signs and symptoms before the age of 6, and we can certainly treat before the age of 6. But we want kids to kind of be on an even playing field. We want them to have had some similar exposure to education and structure and teachers. And as adults, we want to see that the symptoms were present before the age of 12. So one of the things that we're going to do is a really detailed history. This is why we love report cards, because you want to look for patterns and trends in the teacher comments of report cards. And when you see a lot of, is busy distracting the other children with conversations or has trouble focusing, you see that kind of year after year after year on those report cards. That's incredibly helpful. But for adults, that's going to be one of the things that anybody making the diagnosis is going to ask. Well, what were you like in elementary school? What were you like as a small child? How would teachers have described you? Because it's not something that just kind of randomly appears in adulthood. It may not be diagnosed until adulthood, but it definitely was present prior to the age of 12.
Interesting. That was pretty much written on every report card that I ever got. Dr. Hubbard, you're giving me some food for thought here today for sure. Do you think that our teachers here in Newfoundland and Labrador are equipped to deal with this and to spot the signs?
I think there has been a tremendous learning curve in the last, I'd say, 15 years or so in terms of really understanding at least the warning signs, the flags. Because here's the thing, and this is why I love doing this work, but this is why it's so challenging. If I'm presented with, say, a child who is in grade 1 and is looking inattentive, I have to look and do a differential and say, well, let's see. Are there things going on? Are they sleep deprived? Are they having problems? Are they up all night playing video games? And the reason they look inattentive is because they're not getting enough sleep or enough nutrition. What is their nutritional intake like? Because that can also make a kid look really sleepy and inattentive. Are they anxious? If I've got kids with probably the hardest differential I do with young kids is it ADHD or is it anxiety? Because, boy, there's a lot of symptom overlap that goes on there. Are they inattentive because they have a learning disorder or a learning disability? And it's just in class they look inattentive because they're having trouble following what's going on. Do they have a language disorder? Are they experiencing trauma? There are so many things that can be going on that all have a kid look like they're inattentive. Especially in those early years. And that's why it's so important to look and don't do the wait and see. We can, it's always important to raise those concerns. If a teacher is raising concerns, it's usually with really good cause, and it's worth having a discussion, even starting the discussion with your GP, even if it is just okay, we flagged it, let's take a look at the next report card and see how it looks at that point in time.
Okay, great discussion today on ADHD. Thank you so much for that, Dr. Hubbard. Some great information for our listeners out there. I want to bring this up as well. It's also Obsessive Compulsive Disorder Week. So explain to our listeners what obsessive compulsive disorder is.
Well, this is another one that is vastly misunderstood, like I say, partly because of portrayals in, popular media, and also how many times have we all uttered the, well, I'm a little OCD. I like to check things, or I like to wash my hands, or I like to make sure things are in a certain order. And yes, we all do that, and like all anxiety disorders, this does fall on a spectrum. The difference is, for you or I, we might suddenly go, oh my goodness, did I forget to turn off the iron, or did I remember to lock the door? If we're not too far away, you know what? We're going to pop back, we're going to check it once, and then we're going to move on with our day. Someone with OCD has extreme difficulty letting go. So even if they've checked it once, they may have to go back and check that 5 times, 12 times, 20 times. So while for you or I, we might be 5 minutes late for work because we went back and checked, did I unplug that? Did I do what I was supposed to do? OCD symptoms are to a point where they are disabling, where they are interfering with life. In a point that, like I say, they really start to take over. And again, so what we can look at really, again, it's important to kind of define. We've got two things. So obsessions, that's the O part of it, they're unwanted, recurrent, persistent, intrusive thoughts, images, or impulses that cause distress. And the thing that I want to really emphasize is because people think about those impulses that, need to wash the hands, all that kind of thing, or the, concerns about dirt and contamination or germs. What we see for a lot of people, and why it often goes undiagnosed, is they're experiencing intrusive thoughts. So what I call sticky thoughts. And listen, we all have weird, bizarre thoughts that pop through our brain every once in a while, and then they pop out again, right? This happens to all of us. The difference is somebody with OCD, that thought pops in, and it just doesn't go away. I describe it, it's like normally if you had a basketball net where thoughts went through. They come in, they go out the other end, they're gone. Somebody with OCD, that basketball net, it's tied up at the bottom. Those thoughts go in, and they just get stuck in there, and they predominate, and oftentimes they are very distressing. This is often why people don't want to talk about it, because they're concerned, well, somebody's going to think I'm crazy, because they often are involved fears about harm to self, harm to others. Sometimes it's very violent imagery. Sometimes it's stuff that, feels kind of offensive, and they're like, I know I don't have these beliefs. I know I don't have these feelings, so why are they stuck in my brain? Why is this happening so much?
Dr. Hubbard, you just mentioned that OCD is an anxiety disorder, and I really hadn't put 2 and 2 together that it is an anxiety disorder. I would think that having OCD would make someone more anxious, but it's just a manifestation of that, really.
It is a manifestation of the anxiety, absolutely. And it often co-occurs with other anxiety disorders, for sure. And the thing is, so people have these obsessions, and it could be, it could be some strange things like being worried about getting ill. Often there's kind of concerns about being right or wrong, things needing to be just right, especially with really little kids. They can't explain what's going on. They just know it's not right. It's not the way it's supposed to be. I sometimes see that in their written output where they keep erasing and erasing and erasing stuff. And you're kind of going, what's going on? And it's not right. So basically, all of these obsessions cause a certain level of distress. They cause anxiety. So then what happens is, in order to try to reduce that anxiety or that distress, people engage in compulsions. Those are the repetitive behaviors that people do to try to make it feel better. So, for example,
they have some control over the situation.
Exactly. So it's I'm afraid that there are germs on my hands, so I'm going to wash my hands. Again, rational thought we all have, especially in COVID. We're all getting really good at that. The difference is just doing it once isn't enough. Just doing it once doesn't relieve the anxiety, or maybe at first it does, but then you have to do it 2 or 3 times. And it's like scratching an itch. It temporarily relieves it, but then the distress comes back, and you feel like you need to engage in the action again and again and again.
Okay, Dr. Hubbard, we're going to take another quick break here on Target St. John's. Thank you so much for this information. We're going to continue the conversation about obsessive compulsive disorder when we return, and we'll get into learning disabilities, as it is also Learning Disabilities and Dyslexia Awareness Month. Stay tuned. This is On Target St. John's. I'm Carrie Hodder, filling in for Linda Swain.
Now back to Linda Swain on Target St. John's on VOCM.
Good afternoon. It is Carrie Hodder with Dr. Janine Hubbard as my guest on Target St. John's. We are talking about learning disabilities, OCD. We've been talking about ADHD as well. Dr. Hubbard, when it comes to OCD, what are some of the myths surrounding that disorder?
Well, again, I think there's a myth that, well, we all have a little bit of OCD. And unfortunately, well, yes, we all occasionally perhaps have some very minor features. For example, one of them, I joke about this a little bit, one of the things that can occur in OCD is the need for symmetry, the need to do things a certain number of times or for things to be even. I joked, when once upon a time when I worked out at the gym, I used to go behind the girl that I worked out with and rearrange the weights on the pyramid because she'd put them back in the wrong spot, and I'd just go behind her and rearrange them. And they would tease and go, well, is that your OCD flaring up? Well, no, because that's not interfering with my life. That's just apparently I like the things to look even in that way.
Quirk.
But that's not going to, it's okay. I do the same thing with Girl Guide cookies. You have to eat the chocolate and vanilla ones in the same order. But is that interfering with my life? No, of course not. And again, people tend to think about it's all about the lining things up and the germs and the organization. Whereas for a lot of people, it's so funny when I start asking questions, kids think I'm magic because they're like, how on earth did you know about this stuff? Because there's so much of it that isn't visible. So, for example, it could be that they have magic numbers. There are things that they have to do a certain number of times, or the stereo always has to be at a certain number. Or they need to count things a certain number of times, or there's a little ritual. There are these little rituals, little routines that they have developed to try to make things feel better. That might not be visible to the rest of the world. But like I say, I think one of the biggest things are these intrusive thoughts that get stuck. The other, actually probably one of the biggest myths as well is in terms of when OCD occurs, how it occurs. What we actually know, first of all, it occurs in about 1% to 2% of Canadians. So again, the numbers are probably a lot higher than most people would think of. It tends to first occur in childhood. Usually there's kind of two ages, usually sort of between 8 and 12, and then late teens, early adulthood are kind of when it usually first occurs. Average age is about 9 to 10. The good news is if you're over 40 and it hasn't hit you yet, you're probably okay. It very rarely kind of comes up in middle age or older without having had symptoms ahead of time. The thing is, it is a chronic condition. But it doesn't mean you're always suffering from it. Really, it ebbs and flows. So you could have months or even years where you're symptom-free, and then life stresses or life events or your physical health flare up, and all of a sudden you have a flare-up of symptoms again. And then maybe it comes down. Or maybe daily there are a few little symptoms, but you know what? Really, you're able to manage them. I often like giving the analogies. It's a little bit like having asthma. It's always there with you, but you may or may not be experiencing daily symptoms, or sometimes they're there, but they're a minor inconvenience. You get a little wheezy if you're kind of huffing it up the stairs, but overall you're okay. But then you get run down, you get stressed, you maybe get a viral illness, and it flares up to a point that it becomes incapacitating, and it really starts to interfere with life.
Dr. Janine Hubbard is my guest today on Target St. John's. She, of course, is the president of the Association of Psychology of Newfoundland and Labrador. We're talking about ADHD, OCD, and now I'd like to move on, Dr. Hubbard, to learning disabilities and dyslexia. It's also an awareness month for learning disabilities and dyslexia. My first question, I guess, is, isn't dyslexia a learning disability, or is it something different?
Oh, and here's where, bear with me, there's going to be a tiny bit of geeky psychology talk in here. Dyslexia is a terminology that describes a type of a learning disability. For people who are aware, one of the things that we use as psychologists, we use something called the DSM. It's the Diagnostic and Statistical Manual, or there's also a European classification called the ICD-10. These are ways of kind of classifying or labeling a variety of different conditions. in the DSM, we don't actually use the term dyslexia or dysgraphia or dyscalculia, which are kind of commonly referred to versions of LDs, but in reality, that's kind of what we're talking about. We just are using some slightly different terminology. And what you're looking at for the classic dyslexia is a child or an adult who has specific weaknesses in the underpinnings that make up their ability to read and write. In particular, this is why what we refer to them now are specific learning disorders. So, for example, you could have someone who has a specific learning disorder in reading and writing, commonly referred to as dyslexia. So, for example, these may be people who have difficulty understanding their phonics, the very, very basics of what sound does each letter make, okay? Or do I understand the sounds, but how about the letter blends? How about do I understand frequently, common words or common patterns? Like, do I know that ing always sounds like ing, or am I sounding it out every single time I'm looking at it? Do I understand how to break words down into their syllables? Can I tap and say elephant and know that that has 3 syllables, or am I having difficulty figuring out how all of that is broken down? As you can appreciate, if you're struggling with the decoding of that kind of information, you're also then going to struggle with, well, how on earth do I spell a word? How on earth do I write a sentence? And one of the things that we often see in that particular pattern is what we call disfluency. It means kids may be able to read, but it's really choppy and effortful. So again, by the time you get to the end of a word or the end of a sentence, it's really hard to remember what on earth it was that you started the sentence with. So when you're then being asked to say, well, what happened in that sentence? You have to almost go back and reread it a couple of times to kind of get that information because it's been so effortful in the process of getting through it.
So it's the same kind of thing as if I went into some sort of a scientific textbook that I have no idea what they're talking about whatsoever, and I'm looking at word for word, trying to sound it out. If there are all these complicated words, by the end of the sentence, I have no idea what I just read. It's sort of the same type of thing?
It is very much the same kind of thing. And no two individuals with an LD look alike either. So that's why it's so important, why it's such fascinating work, because, I assess kids with LDs all the time, and they all look slightly different. So it's then figuring out, well, where is it that they are struggling, and then it's figuring out what accommodations can we do for them. First of all, how can we try to teach some of those deficits? How can we, really help them to break down? Because most of us just picked up on the phonics or, how many syllables are in a word. We just kind of picked that up automatically. It wasn't something that we needed explicit instruction in. Kids with an LD, something like dyslexia, are going to need explicit instruction. And that's in those early grades. And that's, again, why early identification, early assessment, early intervention is so important in this area and something that we do struggle with in this province. And then as they get older, it's figuring out accommodations. And this is probably one of the coolest areas of development and why I'm so thrilled, again, to be working at it now as opposed to, 15 or 20 years ago. The technology that is available to assist students with figuring out ways to help accommodate for their LD, it's just getting cooler and cooler all the time, and it's also getting more widely accessible. Probably the best thing to come out of COVID, if we see this happen, was the idea of what we call universal design in instruction, so that everybody in the classroom has a Chromebook or a Surface Pro, not just the kid with the LD who's looking different and standing out.
Right. Just the same as when they allowed fidget spinners into the schools and every kid had one. They were originally meant for kids with ADHD to help them focus, and then before you know it, every child in the class had a fidget spinner, and they had to put a stop to it.
And then they banned them all, and then I had to write all kinds of accommodation letters for the kids who really legitimately needed fidgets, and we just found ones that were less distracting for them. But it is amazing, this stuff, and it is constantly changing, and I cannot praise enough the work that the Learning Disabilities Association of Newfoundland and Labrador does in this area. They put off a workshop, I guess it was about a year ago, though time is flying now, all about technology. They offer assistance for families with LDs in terms of what technology might be appropriate. They are keeping up on all the latest and greatest tools that are coming about. So if that is something you are concerned about, I highly recommend getting in touch with the organization and seeing what they might be able to do to help you out.
Okay, so Dr. Hubbard, I guess what I'm going to take away from this today is that people with learning disabilities, ADHD or OCD, they're no less intelligent or no less contributing members of society than someone who was, I don't know, what's the term that I should use for someone with a normal brain?
There you go. Typical.
Neurotypical.
Yeah, neurotypical.
Right, neurotypical. So that's what I'm going to take away from this for sure today. And if there's anybody out there that wants to find out some more information on any of these topics, how can they reach out to the Association of Psychology Newfoundland and Labrador, or again, go through some of those resources that you mentioned earlier in the show?
Sure. I mean, if people want, they're welcome to reach me directly. I'm on Twitter. I'm also manage the APNL email, which is info@apnl.ca if you want to reach us that way, or I'm at Hubbard Janine on Twitter, and people seem to find my email pretty easily for my office. So feel free, reach out. I'm always happy to make sure people have more information on these topics because, as we know, early identification, early supports are so essential. You and I were chatting off air, even just in terms of COVID. We had a recent study come out of Israel that showed that individuals with ADHD who are not taking medication or getting treatment are 50% more likely to catch COVID than people with ADHD who are on medication or people without ADHD. So this can literally be a life-threatening situation, and it's really important to be highlighting and understanding and taking away the stigma. That's why I feel so passionate about these topics and why I want to talk about them every year.
Excellent. Dr. Hubbard, it's been a fascinating conversation. I appreciate your expertise as always. Thank you once again for joining us here on OnTarget St. John's.
Oh, thanks for giving these topics so much of your time. I really appreciate it.